I am Chandra Balani, Deputy Director of the Penn State Cancer Institute, and Miriam Beckner, Professor of Medicine at the Penn State Hershey College of Medicine. There are basically two types of lung cancer, small cell and non-small cell lung cancer. More than a third of the patients present with advanced disease at the time of presentation, which is not amenable to surgical resection or definitive radiation therapy. So these are the patients who have locally advanced or metastatic disease and are candidates for chemotherapeutic intervention, which has shown an improvement in overall survival. We know that two drug combinations which are platinum-based or non-platinum-based are standards of care for patients with advanced disease. And more recently, we have also seen that addition of bevacizumab to chemotherapy has improved survival in patients with non-squamous cell carcinoma. We also know that in patients who have presence of EGFR mutation, there is a role of EGFR tyrosine kinase inhibitors administered as single agents. In the recurrent disease setting, there are three agents which are approved for the treatment of recurrent disease, and these are docetaxel as a single agent, pemetrexed, and erlotinib. Now, lately, we have also seen that there may be a role of maintenance chemotherapy in advanced non-small cell lung cancer after these patients have been treated with initial chemotherapy. And what we heard at ASCO this year, that there is a benefit of pemetrexed in the maintenance setting after 4 cycles of platinum-based chemotherapy. There was not only an improvement in progression-free survival, but also an improvement in overall survival in patients who received maintenance pemetrexed versus placebo after initial 4 cycles of chemotherapy. And we also heard that agent erlotinib given in the same setting after 4 cycles of platinum-based chemotherapy improved progression-free survival, but we did not see any overall improvement in survival in that clinical trial. As we move further along, we see that the agents which are being evaluated in the advanced disease setting include the HDAC inhibitor or histone deacetylase inhibitors and the PARP inhibitors, which have shown early provocative activity, but they are not being utilized as standards of care. So the chemotherapeutic agents which are being evaluated in non-small cell lung cancer at the present point in time include the HDAC inhibitors, the PARP inhibitors, the hedgehog inhibitors, and also a few of the agents which actually work after these patients have failed agents that we described earlier, such as the EGFR tyrosine kinase inhibitors. So it would be of benefit in the future that we head towards personalized therapies or individualized approaches to treatment. So what we will see in the future is that there will be a diagnostic marker or a diagnostic test which would be related to a specific agent which targets a specific receptor or a protein or a gene, so that we can actually improve the overall treatment of our patients with lung cancer in the future. And when we look at resectable early stage disease, we know that there is a role of adjuvant chemotherapy. And most of the benefits of adjuvant chemotherapy in the early stage setting are limited to patients with stage 2 and stage 3A disease. But patients with stage 1B disease who have greater than 4 centimeter size disease also benefit from adjuvant chemotherapy after definitive surgical resection. So we do recommend 4 cycles of platinum-based chemotherapy in that setting. And actually there is a trial looking at addition of bevacizumab to chemotherapy and comparing it to chemotherapy in the adjuvant setting. And there is also a trial which is looking at the role of erlotinib versus placebo in patients who are candidates for adjuvant chemotherapy. So patients actually are divided into two groups, one group who receives chemotherapy and the other group which does not receive chemotherapy, but then they are randomized to erlotinib versus placebo. So as we move forward, and if we are able to validate the biomarkers which are being evaluated in these patients with both early stage and late stage non-small cell lung cancer, we will be able to give specific therapies in this group of patients. So I think with these modest advantage seen with the present systemic therapies that are available to us, hopefully we will be able to improve the overall management and overall survival of these patients with this frustrating disease.